Welcome everyone, dear professors, dear supervisors, dear students. I would like to introduce you my PhD topic, which title is Antimicrobial Therapeutic Drug Monitoring in Critically Ill Patients by Clinical Pharmacists. I am working in the University Pharmacy Department. Here I would like to thank the opportunity that I can take part in this project, which I find really great because my vision in last 5 years of my career, I became interested in critically ill patient and intensive care, and my vision is that the strong cooperation between clinical pharmacists and physicians will be achieved, and to achieve this goal, my mission is to establish a routine drug monitoring service and system in intensive care, and to become an expert in utilization of these TDM monitoring results. I have two ongoing projects. One is a meta-analysis and one is a protocol. Both is related to antibiotics. One is in connection with beta-lactams and the second one is in connection with colistin. I would like to move on with my first project, which is a meta-analysis. Its title is The Impact of Antimicrobial TDM on beta-lactams on the clinical outcomes in critically ill patients based on the pharmacokinetic and pharmacodynamic target attainment. The background of this topic is that around 70% of critically ill patients receive antibiotics, and this critically ill condition is may greatly affect the pharmacokinetic behavior of a given antibiotic. So we are not sure that the targets and the PK/PD indices and targets are reached, and therapeutic drug monitoring can be a tool to achieve these targets. Briefly, TDM is the measurement of drug concentrations not only in blood but in human fluids in specific intervals. However, TDM was introduced decades ago. Nowadays, the focus in the literature is mainly in beta-lactams because this group of antibiotics are the mostly prescribed in critical care, and but we don't know the effectiveness, the added value, and the effects on outcome of TDM. So our aim is to evaluate the impact of antimicrobial TDM on treatment outcome. Here is our PICO. The clinical question is TDM guided beta-lactam antibiotic therapy is more favorable than standard beta-lactam therapy. The population is critically ill patients who are receiving beta-lactam antibiotics. The intervention is when the dosage regimens are adjusted based on TDM results, and the comparator is when it's not adjusted, and our primary outcome will be clinical cure, then secondary microbiological eradication, ICU length of stay, and antimicrobial resistance and mortality. So our hypothesis is that application of dosage regimens based on TDM improves the clinical outcome. The clinical implication of this project is that we would like to improve the clinical outcome, and of course we are facing antibiotic and antimicrobial resistance these days, and we would like to reduce this as well. We set up a search key. You can see I divided the colors to be seen better, and we conducted our search in 3 basic and main databases. Almost 3,000 targets we received, and after selection, 12 full-text articles are eligible. Here we are in this phase, and data extraction comes next. I would like to move on my second project, which is the development of a method for the clinical analysis of colistin and clinical validation and pharmacokinetic investigation of colistin. This is a more complex study because it's actually a protocol writing, but first we have to develop a method for the clinical analysis. I will show you in the upcoming slides. The background of this topic is that colistin belongs to the group of polymyxins. It was discovered in the 1940s. Into therapeutic use, but it was abandoned in the 1970s because of its narrow therapeutic index and nephrotoxicity. But in the last 2 decades, because of the emergence of gram-negative bacteria and superbugs, the resurgence of colistin into therapy was done. And actually nowadays, this is almost the only active ingredient or available antibiotic against multi-drug resistant gram-negative bacteria. However, there is a lack of TDM in this field, so we hope that TDM-guided therapy of colistin can help clinicians to attain pharmacokinetic targets. And as I said, we would like to develop an analytical method to assay colistin in the framework of the TDM. There is a theoretical PICO for the future. Hopefully we will be able to do this PICO in clinical circumstances next summer. The question is how should colistin be dosed and monitored to improve its therapeutic efficiency in critical care. Also, the population is the same. The intervention is administration of colistin by setting individual PK/PD targets, the comparatory standard of care therapy, and the relationship between PK/PD indices and target attainment and clinical improvement will be measured. The clinical implication of this project is to optimize the colistin therapy. But before we will be able to do this PICO, steps should be made. We would like to develop an analytical method. We are in this phase actually for be able to measure colistin in the laboratory medicine department. And then technical validation of this method should be done. Then we will measure the stability studies of colistin in clinical samples. Then the submission of application to obtain the ethical approval for the clinical validation should be also submitted, and then the clinical validation can move on and can be started. And we expect that a complex methodology will be available for the clinicians and for the clinical examination of population pharmacokinetics of colistin. As for conclusion, I would like to emphasize that these two projects are a strong collaboration and cooperation between the intensive care unit, the clinical pharmacy department, and the laboratory medicine department. And with this quote, I would like to finish my presentation. I was told that the way of progress is neither swift nor easy, said by Marie Curie and my parents as well. Thank you.
Congratulations, Eszter. My question is that you are working on the assumption in your second project that every commencement of the antibiotics of colistin is justified. In other words, we have a lot of data that by giving antibiotics unnecessarily in an empirical manner, and this is what we do in the intensive care unit. We basically, 90% of cases, we start antibiotics as an empirical treatment, and about 20 to 30% in cases we shouldn't give antibiotics. So adding a safety feature to your study, I think would increase its scientific value. So to identify those patients in whom colistin should have not started. So, and how are you going to tackle this problem? Because these drugs can have serious side effects.
Yes, thank you very much for your comment. It's true, and I would like to emphasize that this TDM, establishing routine TDM, is a part of the antimicrobial stewardship program. So this includes all these what you mentioned. We would like to set up a protocol that we would like to summarize those patients who are given antibiotics by empirical and by microbiological data. But to tell you, as far as I've seen in our ICU, the physicians prescribe antibiotics, especially colistin, when microbiological data is done, so MIC is measured.
I congratulate you your comprehensive and clear presentation. My question is, have you considered subgroups for your first meta-analysis?
Yes, thank you very much. Yeah, as I mentioned, the data extraction will be just done, but we should make subgroups because we have different kind of beta-lactams, so they can be measured only together in subgroups. Yes.